further ado, we would like to introduce our honored guest today, Dr. Justin Conde, who is the acting director of the Department of Obstetrics and Gynecology at Sidra Medical and Research Center. Throughout his career, Dr. Conde has been active in various aspects of obstetrics, gynecology, and fetal physiology and growth. He has performed clinical work as a physician, published over 150 peer-reviewed papers, textbooks, and book chapters, served on the editorial board of several journals, developed and directed the training programs and services at the University Hospital of Leicester in the UK. I hope I announced that correctly, Dr. Conde. You'll let us know if I haven't. And currently, he serves as an international representative on the Royal College of Obstetricians and Gynecologists Council and sits on the Global Health Board. You can read more about Dr. Conde in the provided bio that we attached to the email that we sent you already, the invitation email. Thank you very much, Dr. Conde, and we are really excited to have you. So I think you are ready to speak.
Thank you very much. Can you hear me?
Yes, I can hear you.
Okay.
Yeah.
Great. Thank you very much, Manis and Elena. Thank you for inviting me to participate in this webinar. It's indeed a pleasure, and I'm not sure how it will pan out. I have seen a few students that have said yes, they are participating. First of all, I would have to apologize to everybody else that some of the slides that I might be showing you are very explicit, but I hope that being explicit will help you understand a bit about your body and hopefully ask me a few questions. Now, I have a few slides that I'm going to share. They're not necessarily my slides, but they're slides that I think you would find extremely useful. So I will now go into share screen. Is that correct?
Yes, correct. Yes, you can go ahead.
So I will go into share screen, and now where is this? There we are. So you can all see the slides.
Yes.
Now, what I'm going to do is I just want to talk briefly about, it's going to be, as Elena has said, it's going to be about the anatomy and the way that the reproductive system functions, and then I will elaborate a bit about sexual activities and what it all means from the clinician's perspective. Now, most people would know about sexuality, and when we talk about sexuality, the first thing that always comes to our minds is sexual intercourse, but actually it isn't. It's much more comprehensive, or much more than sex. It's about thoughts, feelings, behaviors. And these are behaviors associated with the male and the female, experiencing attraction, being in love, and in fact, relationships and intimacy. There is something that we talk about, the circles of sexuality, and I'm not going to spend so much time dwelling on all of this, but just to give you a heads up on sort of things that we're talking about here. Sexualization, flirting. This is a normal thing in young adolescents or adults. Sexual health and reproduction, which is where I come in. Sexual identity, and this is increasingly becoming a problem in the bigger world that we live in. Intimacy, and of course, sensuality. Sexual orientation, it's about how we present ourselves and how we are perceived by others, and we are more in tune with the heterosexual orientation, but of course, increasingly we're having bisexual orientation and homosexual orientation, and there are obviously sexual prejudices which are governed by culture, governed by religion, governed by the environment in which we are brought up. Now, the female sexual anatomy, which is what I'm going to spend the next few slides talking on, consists of the external part, what we call the external genitalia, and the internal genitalia. The external genitalia, the medical terminologies are on this slide. So you have the mons pubis, the labia, the clitoris, the urethral opening, which is where urine comes out, the hymen, and the perineum. And I'm going to show you that. As I say, you have to hopefully not mind seeing this slide. So that's the mons pubis, which is where the hair grows. This is the clitoris. This is where urine comes out. This bit here is hymen, and the you have the inner lips, which we call the labia majora, and the outer lips, which we call the labia minorum. Sorry, the inner lips are called the labia minora, and the outer lips are called the labia majora. And this is where you have the perineum, and this is the anus or the back passage, as we would call it in the UK. In terms of the internal organs, behind the hymen or the entrance to the vagina is the vagina itself, which leads up to the cervix. We call it the neck of the womb. Then from the neck of the womb or the cervix, you go on to the womb itself. Then you have 2 fallopian tubes and 2 ovaries. There will be occasions where individuals may be born with problems. They may not have 1 tube, they may not have 1 ovary. The cervix or the womb may be double, or they may in fact be absent. But those are not normal, those are abnormalities. And this is just trying to show you the relationship between the different parts of the female reproductive system and the rest of the anatomy. So this is the bowel here, and this is the anus here, and this is the uterus here, and the ovary and the tube line on this side here, and that's the bladder. So you can see that sandwich between the bladder in front and the rectum behind is the vagina and part of the uterus, and this bone here lies right in front of the woman. That's what we call the pubic bone. And of course, you can see the pubic mons pubis and the labia here, where you have the pubic hair. And just to take you back to a bit of physiology, a young girl starts growing very fast from around the age of 7 to 8. We call it a growth spurt. And during that time, a lot of physiological changes are occurring. And ultimately, this leads to menstruation, which is what we call puberty. By the time the girl starts menstruating, she would have developed breasts to a certain stage. She would have developed pubic hair. And then she will be producing an egg once a month in most girls. The menstrual cycle is divided into 3 phases. We call them the proliferative phase, which is essentially the phase where the lining of the womb is dividing and dividing and dividing. We then have the second phase called the secretory phase. And I'm going to just show you this slide so you can see that. So we've gone through the proliferative phase here, the secretory phase here, which is where we call them glands within the lining of the womb are producing a lot of things that are helpful if the woman is going to become pregnant. And then if the woman doesn't become pregnant, this part of the womb that is divided is shed, and that comes with blood, and that is called menstruation. So we have these 3 phases: the proliferative phase, the secretory phase, and the menstrual phase. And ovulation, when the woman releases an egg, happens towards the end of the proliferative phase, and following that you have the secretory phase. And it's usually at this particular stage here where pregnancy occurs. So shortly after ovulation, pregnancy will occur, but that pregnancy will travel along the tube, and then it's rested in the lining of the womb around this phase of the menstrual cycle here. So just moving on, and this is just illustrating what I've said in this diagram here. And this is showing you where the eggs are released here, and following the release of the egg, the body produces certain hormones called progesterone. And you can see that this is a lining of the womb which gets thicker and thicker and thicker. And once this little thing here starts shrinking, then you have a withdrawal bleed, which causes menstruation. What sort of menstrual problems do young women or young girls and possibly other women experience? The most common one is premenstrual syndrome, which, as the name implies, symptoms that tend to occur usually around menstruation. I can talk a bit more about that if questions arise. The very severe type is called PMDD, which is premenstrual dysphoric disorder. And if it becomes very severe, obviously, we sometimes will get help from different types of clinicians. The toxic shock syndrome is one thing that is more common in the parts of the world where women use tampons during menstruation. And dysmenorrhea is painful periods. And then towards the end of reproduction in the woman is something called menopause. And here the woman stops producing eggs. And when you stop producing eggs, you also stop menstruating. And it tends to occur usually after the age of 40. In most parts of the world, it's around 50, 51. And here, because of the lack of estrogen, some women may go for estrogen replacement therapy, what we call HRT. And then I'm now going to just switch very briefly to the male sexual anatomy. Just like the female sexual anatomy, you have the external genitalia, and these are just two, the penis and the scrotum. And then the internal genitalia, you have the testis, the epididymis, the vas deferens, urethra, the seminal vesicles, prostate glands, and these are all very technical terms which are shown in this figure. But that is the penis here, this is the testis here, and this is the vas deferens. So it carries sperms which are produced in this testis here, right down, and then the sperms are joined by fluids produced from the prostate glands, and then they'll come out during ejaculation as semen. Now, just moving on to the last part of my short presentation, very briefly to talk about human sexual responses. We talk about almost 4 phases of sexual response. There's the phase of like excitement or arousal. There's the plateau phase, the orgasmic phase, and resolution. I'm not going to go into details of this for this first presentation today. Perhaps if we had to do more presentations, depending on the response, I might go into this a bit. And this is illustrated in these 2 slides here. This is the man on this side here, and this is the woman on this side. And you can see that both gender undergo these 4 phases of sexual response. Arousal in the man and the woman, plateau in the man and the woman. Then you have the orgasmic phase in both, and resolution in both as well. As the woman is getting older, and as the man is getting older as well, the hormones that you produce obviously the levels tend to fall, and that tends to affect sexual responses. So the woman is a bit slower, and so is the man. So you can see that in the man, erection is less firm, ejaculation intensity is much less, and premature ejaculation is more common in the older men. What sort of sexual behaviors are common in the younger and perhaps not very old generation? They can have sexual intercourse itself, they can have orgasm, it may be 2-person, it may be masturbation. And of course, in this day and age, we always talk about safe sex because that is what can cause problems. What are the typical sexual disorders that we have? Lack of desire. Either the man or the woman don't have a desire for sexual intercourse at all. The man may have the desire, but cannot have an erection. The woman may not be able to have an orgasm, or the man may have premature ejaculation. And a significant number of people have anxiety about how they perform during sexual intercourse because of either fear or because they have very, very poor knowledge about what is going on. And then from a much more severe perspective, you have painful sexual intercourse, which a small proportion of women will experience, and that painful intercourse can be during penetration or after penetration. And some of them will have what we call vaginismus, which you have an involuntary contraction of the muscles of the vagina stopping penetration. And for most of these people, the first thing is that it isn't clinically or classically abnormal, and there is help. And my final slide is just to say that things like drugs, alcohol, do in fact influence sexual functions in both men and women. And I think I'm just going to end by saying we've got to be very careful about the implications of sexual activities, irrespective of how old you are, because of the consequences that may happen long-term, both in terms of your ability to have children, to enjoy sex, and also in terms of long-term health. So I will stop there, and I will obviously take questions. Hello? Hello?
Sorry, there we go. Can you hear me now?
Yeah, that's right.
Okay, so I just wanted to say thank you very much. It was a really great presentation, and we've already had a couple of questions, but for those who are participating, please feel free to send me any additional questions. Again, you send it in the chat to Elena, and I'll say host next to it, and we will then share it. So one of the questions we had to do with whether or not there are any harms of not menstruating after the age of 40.
No, once you reach menopause, there is absolutely no harm not menstruating. In fact, we can actually stop women from menstruating with different hormonal manipulations, and it doesn't cause any harm at all. The myth that if you don't menstruate, the blood is going back inside is absolutely untrue.
Okay. What about any harms associated with not ejaculating for men, obviously?
Well, there isn't any harm at all not ejaculating. In terms of how the male functions, the sperms are produced every 90 to 120 days, and they just come and go, and they come and go. So without ejaculating isn't a problem. You don't have to ejaculate to be normal. And even if you do ejaculate, whether you ejaculate as part of a wet dream, it doesn't cause any harm at all.
Okay.
We have another question here. This is Mahnaz here, Dr. Kundry.
Yeah.
Well, one of the questions is, sorry, we have a little feedback here. Hold on. Yeah. Okay. Do you hear me okay?
Yes, I can hear you, yeah.
There is a question about what can a person do about premature ejaculation? Because as you know, in young people, that can be a concern for young male.
Well, there are quite a few things that can be done about premature ejaculation. One of them is obviously how you prepare yourself psychologically. A lot of people who suffer from premature ejaculation, they get themselves into a cycle that cycle is perpetuated. When they think about sex, they're frightened that they're going to have premature ejaculation. It just goes on and on and on. Now, one way in which you can overcome that, first of all, is to say that premature ejaculation for a lot of young people is not abnormal. That's the first thing. Now, once you classify yourself, you label yourself as being abnormal, then you perpetuate that belief, and that belief tends to affect the way your body functions. So for a lot of young people, premature ejaculation is not abnormal. Now, what then happens with time, over time, is that once you realize that it is not abnormal, and you start mentally preparing yourself, you can overcome that. Now, there are certain approaches that you can use to overcome that. Some of them will be how you interact with your partner and how you prepare yourself towards having penetrative sexual intercourse. Now, if those approaches fail, there are what we call psychosexual counselors who can spend time talking to individuals who have those problems and deal with those problems and provide additional ways by which you can overcome a premature ejaculation.
Okay, I do appreciate that, and I just want to students know here that I have done in my career. I've done the psychosexual education, and if anybody has any among the audience, they can come to me, and Georgetown students, obviously, not other students. They can come to me, and they know that all our sessions are confidential as well. I do also have another question. We're waiting for other students to post question. Please post your question as we go along. But I have a question about pregnancy and birth control. Would it be, I know it's a generic topic and a question, probably a lot of information into that, but some of the fears of people are how can they get pregnant, what are ways of birth control, and what they need to keep in mind.
Okay, the first thing that I need to say is that for pregnancy to occur, the sperm needs to meet the egg. You need penetrative sex for pregnancy to occur. Now, I did some research in the UK where I used to hear young girls asking me, if you sit on a toilet seat where somebody has just deposited some sperms, can you become pregnant? And the answer is no, you can't. But the other thing is, if you had penetrative sexual intercourse and you have a withdrawal ejaculation, that is not safe enough, because by the time that the male partner is about to ejaculate, he would have released some drops of semen that will contain sperm. So you can become pregnant even though you've had what is called withdrawal ejaculation. Now, for the girl to become pregnant, she must be able to produce an egg, and the man, she must have sperm that are viable. You can prevent that by several ways. One of them is using a barrier method of contraception, which we now have we have the condom, both the male and the female condom. There are many advantages of using the condoms, some of which are prevention of sexually transmitted infections, which could potentially then affect the fertility potential of both the girl and the boy. We also have the female condom, but then you have the combined contraceptive pill, which the girl can take. You have what we call implants, so you can stick it in your arm and it will last for 2-3 years. We have contraception now you can take in the form of vaginal rings, in form of patches. So there are all sorts of contraceptions that you can take to prevent pregnancy. But for young people, one of the safest ones is the condom if it's applied properly, because it reduces the risk of sexually transmitted infections. But of course, if you don't apply them properly or the burst, then there's a potential that you may have accidental pregnancies.
Sorry, we're both trying to mute and unmute. Thank you. Another question we had was, what is the normal sex drive for males and females through the different age groups?
Oh, that's a difficult one. I'm not quite sure what exactly that means. I mean, I would struggle to answer that, but I would. It's normal for the male sex drive to be much greater than the female sex drive. That's normal. The woman takes more time to respond to her sexual needs than the man. And so all I can say is that from about the age of 14, 15, once the hormones are being produced, sexual feelings begin to occur and they rise. And of course, the society is not helping, because everywhere you look, we're being shown all sorts of things that encourage people's sexual drive. So you'll probably find that the peak at which the sexual drive in the reproductive age group happens is around the age of probably 20 to about 30. And then thereafter, it plateaus up till around the age of 35, and then starts falling in the woman, and then probably in the man starts falling after the age of 40. So that's perhaps the only way I can respond to that question.
I think that was quite good for a very concise response. There's been a question about whether or not it's true about whether or not the hymen could be ruptured by things like exercise or a bumpy car ride or anything like that. Or I think there's just a general concern about the hymen and it's being ruptured outside of just penetrative sex.
No, exercise wouldn't rupture the hymen. Neither would if for example somebody inserts things like tampons, they can cause minor trauma. In fact, they could rupture the hymen. But other than that, the only one that I've seen is somebody falling astride and having a penetrative injury that causes damage to the hymen. The hymen is actually quite tough, so it doesn't just give way that easily.
Right. Well, thank you for your response to that. There is another question from a student, and I know that it may not fall under your expertise here, but it's more about general promotion of awareness about protected sex, especially in college students and in general in Qatar. You know, they're saying that some colleges in the US, because as you know, we are a US French campus, there is quite a lot of conversation about STDs and protection and birth control and all that. And actually some universities, they may even distribute some sort of a birth control modalities like condom, although on main campus, Georgetown main campus, we cannot do that because we are a Jesuit university. However, I was wondering if you have anything to speak to that in general, especially that you are the acting chair in CEDRA.
We have to recognize the cultural and religious sensitivities of the environment in which we work. I spend most of my time working in the UK, where, I mean, I was in the university where I worked. We didn't go as far as distributing condoms to students, but most of the toilets that we had in the UK, you have dispensing machines where you put in a few coins and you get contraception coming out. I think the students are absolutely right in the sense that there's a lot of ignorance about sexuality. And the best way to address the ignorance is to perhaps promote the kind of activities that the students have spoken about. And in fact, what we've done today, it's perhaps trying to move in the direction of promoting that. I'm not quite sure how we can do that within the environment in which we work, other than what we're doing now. And I think all that I can say is, from a perspective of us who are working here, we would like to promote the health of young men and young women as much as possible within this country, also sticking to the rules and the laws of the country. And if what we've done today, if it's successful, there should be opportunities for us to do more to try and answer some of the questions that they have and help the students in whichever way we can. I mean, that's the only way that I suspect we can perhaps help your students and the younger generation here.
So another question has to do with what, if any, extra care would need to be taken in terms of hygiene for uncircumcised males? And is there also a higher risk of infection or diseases, et cetera, in uncircumcised males?
No. The interesting thing is that most circumcision is not a common thing in the UK. So most, in fact, it's not a common thing in Europe. Most Europeans are uncircumcised. And it isn't an issue, not at all.
Okay.
That's yeah.
Another question is there any relation between spinal injury and sexual dysfunctioning for males?
Yes, there is. If you are paralyzed, if you have a significant spinal injury, then you will struggle to have an erection, but it doesn't stop you from producing sperms, because the sperm that you produce are controlled by a gland in the brain, and they work independently of the communication that occurs between the spinal cord and the way you move. So if, unfortunately, you have a spinal injury that makes you paralyzed, you will not be able to have erection and therefore penetrative sexual activity, but you can still have children. And the way you have children nowadays is we would harvest the sperms from the testicles and do something which we call ICSI, which is you harvest the sperms, take the egg from the woman, fertilized, and then put the embryo back into the woman.
Thank you. Another question is, some females have a discharge that's maybe not necessarily associated with menstruation. How would one know what is considered normal versus abnormal? Is there an amount or consistency that one should be looking out for or be concerned about?
Okay, that's a very good question. We would expect every woman in the reproductive age group to have a certain degree of discharge. The discharge tends to be greatest around mid-cycle, so when you're just about to ovulate, and it tends to be clear and watery and very drawy. In fact, we can use that to determine whether the woman is ovulating or not. There's something that the Catholics use as a form of contraception called the Billings method, which essentially check for the stickiness and the stretchiness of the secretion that comes out of the vagina. And these secretions come from glands that are located around the cervix or the neck of the womb. It can vary from being clear, watery to a bit whitish. Now, also you find some women may have a bit of a brownish discharge just before menstruation and after menstruation. Now, if the discharge is thick, if it's irritating, if it's greenish, if it's smelly, then that is abnormal. There are some women who will have a very, very heavy discharge, and that is often in a significant number of women linked to what I call being too female. So you produce lots of estrogens that change the appearance of the cervix, and that exposes the cervix to normal bacteria in the vagina, and that it's an irritation. And we will call that leukorrhea, which is a physiological thing, but it's not pathology. But if the discharge that you have is requiring you to wear some protection, then you need to get somebody to check it just to make sure that it isn't abnormal. So what I'll be saying is, if it's enough for you to wear protection, if it's smelly, if it's persistently brownish, it's greenish, or it's thick, and you have irritation or itching, or it's bloody, then it needs to be checked. Otherwise, anything else will be normal.
Thank you, Dr. Condre. And there is another question that a lot of students usually talk about. Could you get pregnant through foreplay?
No. It's just a straight answer is no.
Okay.
If there's foreplay and there's no penetration, the answer is no. Once you have penetration, then there is always the risk that you can become pregnant.
Okay, thank you. Now I'm turning the question to a bit about the difference between sexual orientation and transgender and how they affect a person's sexuality, just general kind of information given.
Sexual orientation is, I mean, it's, you know, you will get some people who physiologically they will be males, but they will portray themselves as females, and some of it is pathological. So there's something that is, they're not, so there's something that they see themselves more as women rather than men, but they can function as men, so they can still have penetrative sexual intercourse. And those people can eventually, in Europe and North America, undergo sex change. And then I know of a few people that have gone on to have sex change to become women because they felt that they've always been women, although they're brought like men. Some of them actually have children, then they go on to become women. Now, transgender is slightly different, but again, all of it is linked to orientation and then how you end up perceiving yourself and wanting to be perceived. It's rearing its head now much more than it was in the past, and that is because people are accepting a bit more. If you take just going to sexual orientation, you have people who are gays, so they prefer the same sex. Now, when I was a bit younger, we didn't hear about it. Nobody talked about it, but societies, at least the Western societies, are much more accepting of this. So it's rearing themselves a lot more now. And I think in societies where it's still a taboo to talk about it, they do exist, but they exist behind the scenes.
Thank you. Another question has to do with what are some of the sexually transmitted infections that people should be aware of and that maybe are common in a college-age population, and whether or not condoms are effective at preventing them, as well as kind of the second part, what are some of the reactions to look for that might be an indication that you've been infected?
Okay.
Thank you.
Yeah. The two most common sexually transmitted infections are chlamydia and gonorrhea. But other sexually transmitted infections that are important will be HIV, will be hepatitis B. Now we have human papillomavirus, which we now know causes, is associated with cervical cancer and sometimes cancer of the throat and the penis. But for the two most common ones, chlamydia, that's probably the most common one in the college age group and the younger women and men. And the reason why it's more common is because a significant number of people will not have severe symptoms. Gonorrhea will also cause, it's also common, but people tend to be treated much more easily with gonorrhea because gonorrhea will cause a purulent discharge that's almost like pus coming out of the vagina or from the urethra, and painful. When you're passing urine, it's painful. Now, with gonorrhea, you tend to get the symptoms appearing about 2-3 days after the sexual encounter. Chlamydia can also present with a burning sensation when you're passing water. For the women, it may present with lower pains in the abdomen. It may present with pain in the right part of the abdomen. And that the symptoms tend to occur usually about 5 to 6 days after the sexual encounter. If you have those sort of symptoms, you need to seek some advice and treatment. The good thing is that they can be cured, treated very, very easily. But if they're not treated and they carry on for some time, then they can damage the fallopian tubes in the woman, leaving the woman with what we call tubal infertility. And in the man, it can also cause severe damage to the vas deferens and the epididymis, causing the man to produce what we call azoospermia, no sperms, or very poor quality sperms. And so again, having difficulties being able to father a child. So those are the common ones. Now, in terms of protection, the barrier method of contraception is effective in protection, but of course, it is not as effective in preventing unwanted pregnancies like the hormonal methods, like the combined pill, because it depends on the user and the user applying the condoms properly and the condoms not bursting. But if you are using, if a young girl wants to protect herself, she should go on the pill, but at the same time, she shouldn't have intercourse with a partner without encouraging him to wear the condom, because that at least gives her double protection. If the condom bursts, she won't become pregnant, and she prevents herself from having a sexually transmitted infection. The same applies to the young man.
Okay, thank you. And I have a follow-up question on that, actually. You mentioned about HPV. I was wondering, how is the state of vaccination in Qatar, and for young girls, if they want to get vaccination, what is the best route that they can take here in the country?
I am not aware of the HPV vaccine being available in Qatar. It may just be that I'm completely ignorant, but what I can promise to do is to investigate, and if we did have another session, I will perhaps give you the answer. I know that in the UK, we are now vaccinating all our young girls in school between the ages of, I think, 12 and 13 to prevent them from the infection that then causes cervical cancer.
Okay. Also about HIV and AIDS. Could you give us a little bit of information about what to look for when they notice any symptoms, what those symptoms could be, and how they can check for that?
HIV is a very difficult one because most of the time it is silent. You may have HIV for quite some time before you actually develop the symptoms of anything, because it eats at your natural immune system, and it has to really eat that natural immune system below a certain level before your ability to fight ordinary infections becomes poor. So we'll be saying that if you suddenly have a cough that is not, it's a very simple cough that is not going away, and I'm very cautious about the comments I'm making, because there are quite a lot of people who have an irritating cough that doesn't go away. It's not because they have HIV. But if you have something that you would expect it should go away very easily and it's not going away, and you think you might have been exposed to somebody who may have HIV, then it's worth checking. But most of the time, the patients who have HIV that is beginning to manifest themselves with symptoms, they have infections that are difficult to control, chest infections, they have boils on their skin, their scalp. They may have a vaginal infection that it's not going away. And then they may start losing weight, but that's very, very, almost like very far into the infection itself. And it sometimes takes years before they start manifesting the symptoms. So all I'll be saying is it takes time. Thankfully, in this country, they screen a lot of people for HIV. But for those who do travel outside and have sexual encounters outside, please be extremely careful and take the precautions. If you use the condom, it offers protection. If you use condoms which have certain spermicides, it even offers you more protection.
Thank you. We've had a couple of questions having to do with oral sex. In general, are there any health concerns with oral sex? Is it unhygienic? And a more specific question was related to cold sores and whether or not if someone has mouth ulcers, if that can be transferred to the genitalia during oral sex.
Okay, oral sex itself has no health implications for the individuals unless it is with somebody who has a genital infection. Now, if somebody has, we have seen herpes of the back of the throat. If somebody's got herpes on his penis and they have oral sex, then that infection can be transmitted. The same will apply to human papillomavirus. So we're talking about herpes and human papillomavirus, and very occasionally we'll get gonorrhea and chlamydia transmitted through oral sex, but they're not rare, but they can happen. And the second part was a cold sores. Now, if most cold sores are harmless, they will not be transmitted sexually. But if it's herpes, then herpes can be transmitted. But again, that is right. You need to have an abrasion on the penis for the transmission to occur. If there's no abrasion, then it's less likely to happen.
And a second question, and kind of going along, a lot of women might choose to have anal sex instead of vaginal penetrative sex so that they can still remain a virgin. And irrespective of male or female having anal sex, what are some things to be concerned about or precautions to take in engaging in that behavior?
The only comment is that anal sex again exposes individuals to the risk of infection, just like penetrative sex. The difference is that the woman will not become pregnant through anal sex, and very occasionally it could tear the muscles around the entrance of the anus, and that could potentially affect the ability to control fecal matter. But again, we're seeing what we call gonococcal proctitis, which is gonorrhea that has infected the back passage, or chlamydia proctitis, which is chlamydia that has affected the back passage. Other than that, again, if that has to happen, then the same precautions will apply, because most of these infections, they will affect the lining of the bowel, just like they will affect the lining of the urethra or the lining of the womb. And so then the same precautions will apply.
Another question has to do with appropriate use of lubrication with condoms. That there's a lot of different things that people choose to use, whether it's maybe a KY jelly, Astroglide, or even Vaseline. And what are the do's and the don'ts of what should be used?
Most condoms will have, in fact, I think all condoms have a lubricant. Those lubricants are spermicidals, so they kill the sperms and make it more difficult for the sperms to penetrate. Using lubrication will not, as long as it isn't anything that is acidic, could potentially damage the condom itself. That risk of damage is small, but it's there. So you avoid using anything that is acidic, which could damage the sperm. But Vaseline or KY jelly shouldn't be an issue.
All right, thank you. And a question about just the birth control pills. What are the advantages and disadvantages of that for?
Okay, there are several advantages of the birth control pill. There are different types of birth control pills. You have what we call the combined oral contraceptive pill, which is probably the more common, and then you have the mini pill. The combined oral contraceptive pill has many advantages. ranging from reducing the risks of, apart from preventing the young girl from becoming pregnant, it also reduces the risk of sexually transmitted disease in a way that it makes the secretions to the neck of the womb much thicker, and therefore reducing the risk of infections climbing up into the womb itself and through the fallopian tubes. That's number one. Then there are medical benefits in the sense that women who have used the combined pill for a long time, their risk of having cancer of the ovary and cancer of the bowel is much less, as well as cancer of the lining of the womb. But those are long-term benefits. In terms of the potential risks, the risk of somebody who is on the pill having a blood clot in her leg is slightly higher than the risk of somebody who is not on the pill, but significantly much lower than the risk of having a blood clot in pregnancy. And if you've used the combined pill for more than 5 years, it also slightly increases the risk of breast cancer. But once you come off the pill after a few years, that risk is reduced almost back to normal. So those are some of the risks that are associated with the pill, but the benefits are much more than the risks that I've mentioned.
Another question is related to the polycystic ovarian syndrome, I believe, PCOS. It's a common syndrome here for many women. If you could just explain a little bit about what it is and how it impacts the woman's, both her own fertility and other sort of systems, its impact on her other systems.
Wow, that's a very, very long question. Polycystic ovarian syndrome is a big, big topic. Well, the first thing that I would say is it is very common in the Gulf. It's also very common in Asia. It's actually quite, I mean, we'll probably say that about 20% of the women in the UK will suffer from polycystic ovaries. Now, I haven't said polycystic ovary syndrome because there's a spectrum going from polycystic ovaries to polycystic ovary syndrome. Now, polycystic ovary simply means you have an ultrasound scan and you have multiple cysts in your ovaries and you have no symptoms at all. Now, polycystic ovary syndrome then includes the appearance of your ovaries plus certain things that include you may have even very infrequent periods, you may have no periods at all, you may be overweight, you may have excessive hair on your face, on your tummy, on your thighs where you don't normally have hair, you may have acne. And those are the typical things that will come with polycystic ovary syndrome. And for a lot of young girls, the issues are usually the weight and the acne that worry them. Now, the infrequent periods, the only problem with them is that you cannot predict when your periods will happen, and sometimes when they go for a long time before they happen, they then become quite heavy. And so those are medical issues that can be addressed. Now, in terms of the effect on fertility, some of them, because they're having very infrequent periods, they'll be producing eggs very infrequently, which means it may take much longer for them to become pregnant. Some may struggle to become pregnant at all because they're not producing eggs, because these polycystic ovaries, they are immature eggs in the ovaries. And so medically, we now have a better way of dealing with it in terms of we can control the periods, make them have periods regularly by giving them pills. We can control, some of the pills will control the excessive hair, control the acne. And then in terms of pregnancy, we now have different ways of making women ovulate and do that very well. In terms of general health, my advice would be if you have polycystic ovaries, watch your weight, because I think if you control your weight very well, it actually tends to improve the way that your polycystic ovary syndrome affects you in a very big way. You tend to have your periods become regular, the excessive hair reduces, the acne reduces, and we would say if you lose 10 to 15% of your weight, you tend to get your cycles go back to normal. In terms of long-term, there's a big link between diabetes and polycystic ovary syndrome. So we know that if you have polycystic ovary syndrome, you're more likely to have diabetes much older and perhaps have high blood pressure. And that's why it's important to watch your weight and watch what you eat.
All right. So the last question, I know we're running out of time here, but it's on premenstrual syndrome, PMS.
Yeah.
What are, in general, like what are some of the symptoms and what can a person do about that?
Okay, I touched on that very briefly, just mentioned it, and then we went to the extreme, the dysphoric disorder. A large proportion of women will experience premenstrual syndromes, and it's primarily because of the way that the body functions, the hormones that are produced. We talked about the three phases of the menstrual cycle. In the proliferative phase, which is the phase where there's a lot of the lining of the womb is dividing, the woman produces estrogens, and the estrogen levels are very high. And then once she ovulates, she starts producing a progesterone, and the progesterone levels rise. And then if she's not pregnant, progesterone levels fall and estrogen levels fall. That fall links up with a lot of changes that occur in the body, and that we believe is what triggers premenstrual syndrome. So you may have premenstrual syndrome starting a few, maybe 3-4 days before menstruation, and then continuing up to a few days after menstruation in those that have very severe symptoms. In others, once menstruation starts, it gets better. And they tend to they get irritable, they get a bit depressed, they may feel a bit bloated, they may have headaches, they may find that concentration is a bit poor, just a combination of symptoms. Now, there are some that become quite aggressive, that's the real extreme. I mean, I remember seeing a patient in the UK, and it was a husband who was actually talking that every month I have to buy a new set of plates in the house because my wife has broken everything. She gets very, very angry, and then she just breaks everything and she flies off the handle quite easily. But those are extremes. So most women, it's just get mood changes, they get a bit depressed, they get a bit irritated, they may not concentrate very well in class, and then they argue much more easily. And then it stops there. What can you do to help it? There are quite a few things that you can do. Exercises help because it refocuses the body's physiology. People have talked about evening primrose. Now people have talked about vitamin B6. Some people say it works very well. Others say it doesn't work very well. But if you have very severe premenstrual syndrome, the one that is beginning to affect you, putting somebody on the combined pill, which stops them producing an egg, so it stops ovulation, and it stops the level of progesterone going up and falling, that has been shown to be quite effective in a large number of people. So those are the sort of key things that I probably talk about, yeah.
Well, thank you so much. I see we are exactly at the 1:30 mark, and so I want to thank you for your time.